Hello, my name is Dr. Stephanie Peat and I'm a clinical lead for UCLPartners working for the Proactive Care team. And today I'll be presenting the framework for atrial fibrillation. Next slide, please. So COVID-19 has placed an unprecedented pressure on our healthcare system, and this has meant an added risk to those people that suffer with long-term conditions who ordinarily need quite a lot of proactive care in order to stay well and in order to avoid exacerbations of their condition. This disruption has meant they are no longer having that care. As primary care has evolved and transformed in order to respond to the pandemic, UCLPartners has developed a series of frameworks that support proactive care of long-term conditions. The framework includes pathways for remote care, virtual consultations, and a more personalised care. It also optimises the wider workforce to support practices to deliver good healthcare for these patients. The frameworks are supported by a selection of digital tools, all of which have been validated and appraised. There's also a package of training and other resources to support patients. This work has been designed and led by primary care clinicians for clinicians and is underpinned and informed by patient and public feedback. UCLPartners frameworks support packages will help primary care networks and practices to prioritise patients in challenging circumstances. It will allow them to focus their resources and optimise the care for patients that are deemed to be the highest risk. So the core principles of all of our proactive care frameworks are that they are virtual by default. They mobilise and support the wider workforce, mapping out which person from your workforce will be best placed to deliver care. It also gives us an opportunity to try and encourage patients to make that step change in order to start to self-manage their conditions. We also use digital innovation, including apps for self-management and technology for remote monitoring. So this slide just shows you the overview of all the frameworks. They all start with the stratification process, and what that means is looking at which patients fall into which groups. So the groups are, loosely speaking, low priority, medium priority, and then those in the high risk groups. These are stratified not only according to clinical need, but also around other parameters that make these patients vulnerable. And you would start with the highest priority. You'd use your wider workforce mapped against skills. So your HCA would be really well placed to look after your low priority group. Next slide, please. So the focus for this presentation is atrial fibrillation. It's a common condition, as you well know, and it leads to a 5-fold increased risk of stroke. If not anticoagulated, 25% of people who experience an AF-related stroke will die. And we know that most people will benefit from oral anticoagulation, and it significantly outweighs the risk. We need to look carefully at our patients that are treated with anticoagulation because we need to make more effort to address modifiable bleeding risks. This allows patients to be safely anticoagulated and monitored. We need to consider using more proton pump inhibitors. These are definitely underused in these high risk groups. Next, please. The atrial fibrillation pathway starts, as all our pathways start, with the stratification of patients in this cohort. So you will download the searches, either using EMIS or System 1 appropriate searches, and these will then pull out patients in either a priority 1, 2, 3, 4, 5 group. Priority 1 are those most high risk patients. They are deemed to have atrial fibrillation, but they are not on any oral anticoagulant. Patients in group 2 are those with AF on anticoagulation, but not on antiplatelet therapy. Patient 3 are those on warfarin. So priority 3 are those on warfarin, and groups 4 and 5 are those patients with AF on a DOAC, but either with an up-to-date renal function or needing an up-to-date renal function. The link is a hyperlink that will take you to the most appropriate slide. At the top, you can see that there's a role for a healthcare assistant for all patients, regardless of which of the priority groups they fall into. So that's important to remember, that each of those patients will need up-to-date bloods and weight. They'll need some support with smoking if they are smokers, up-to-date CHA2DS2-VAS and HAS-BLED scores. They'll also need signposting to various self-management tools and resources. And they will need some support, coaching support, perhaps to actively lead a healthier lifestyle. However, there's definitely a role for the prescribing clinician, and the bottom box shows you the types of intervention that the clinician will need to make to optimise care of each of these priority groups. Next slide, please. This is a contents slide and shows you the different resources and pathways in this pathway. Each of those bullet points 1 to 9 will take you to the relevant slide. So let's start with initiating DOACs. So this applies particularly to those patients that are in priority group 1, those with AF that are not currently treated with any oral anticoagulation. The left-hand side takes you through the actions that you would use. It's a tick box list, really, for you to decide whether or not your patient would be eligible for oral anticoagulation. You will need to take a step-by-step approach and even do some pre-checks, including blood tests, body weight and creatinine clearance. You will need to calculate their HAS-BLED score. You will also then, once you've decided that the patient is eligible, need to go through a shared decision-making process with your patient to decide that this is the right choice for them. You might want to counsel the patient as well and agree some follow-up with them. Next slide. In making your assessment, it's important to understand that each patient will have an individual stroke risk. So you need to calculate the stroke risk using the CHA2DS2-VAS score. This CHA2DS2-VAS score modification here just shows you a quick overview of which parameters are important to identify, either in discussion with the patient or by using the patient's notes. You will use these parameters to calculate a score and then decide whether the patient is high risk for stroke and therefore needing oral anticoagulation. On the right-hand side is bleeding risk, and you need to calculate again for each individual patient their own HAS-BLED score, which will give you an indication of that patient's likelihood of bleeding if started on an oral anticoagulation. It's important to understand that bleeding risk can be modified, and so the bottom box there tells you how to modify bleeding risk. Next slide, please. All DOACs rely on having an up-to-date renal function, and it's important to calculate renal function using creatinine clearance and never using a glomerular filtration rate. In fact, the dosing for all DOACs is based on creatinine clearance. It's also based on using actual body weight. So creatinine clearance relies on you understanding the actual body weight for the patient. And if you have a patient with a particularly low or a particularly high BMI, you would need to seek specialist advice. Make sure the renal function is up to date and calculated within the last 3 months, and then go on to calculate the creatinine clearance using the Cockcroft-Gault equation. There is a link here to MedCal, which is an online calculation. In the green box there, you will see that depending on creatinine clearance, there is a different interval for monitoring renal function. And you may well need to adjust the dose of your DOAC according to renal function. So this slide shows you the 4 main DOACs used to treat non-valvular AF. Across the top, it shows you the standard dose and then the renal dose. It's important to remember that dose is often reduced not just for renal function, but also in those patients that are elderly, those with a low body weight, and sometimes depending on a medication that the patient may be taking. The other important point to make is that all DOACs are contraindicated in those patients with significant impairment to renal function. The bottom box here shows that there are some common drug interactions with DOACs and possible contraindications, and there are a number of different medicines that a patient may be taking that would increase the bleeding risk. So once you've initiated your patient on a DOAC, you would start a review at 1 month post-initiation, but then for all patients, you would monitor them and review them at least annually. So an annual review for a patient on a DOAC would include taking an FBC, a renal and liver function, calculating a creatinine clearance and getting an up-to-date weight. There are circumstances where you may need to reduce this interval for monitoring, and these include patients with reduced renal function, those that are frail and those that are elderly. Now, the blue box here is an annual clinical review checklist for patients on either DOACs or warfarin. All of these patients need to be reassessed for their stroke risk, including a CHA2DS2-VASc score. They will need up-to-date Q risk calculation and management of their cardiovascular risk factors. You would want to address any bleeding risks, and then you would do a medication review and check their adherence, review any medicines and change doses appropriately. You'd also want to talk through missed and delayed dose advice and give them or make sure they have an alert card with them. So there are certain circumstances where a patient may need a particular DOAC, and this is just a slide that will show you some of the considerations that you may need to look at when choosing a suitable DOAC. So you may remember from our search criteria that one of the priority groups, priority group 2, shows that some patients will be on oral anticoagulation and antiplatelet therapy. There may also be circumstances when patients are on antiplatelet therapy who then slip into AF and require oral anticoagulation. An important take-home message is that antiplatelet therapy is not recommended for stroke prevention in AF, and oral anticoagulation should be used. The green box here shows you the indication for antiplatelet therapy: primary care prevention of cardiovascular disease, secondary prevention for cardiovascular disease, and patients with an ACS or stent placement within the last 12 months, and then those patients who've had a previous ACS or stent placement but are more than 12 months after that intervention. In the middle there, it will show you the type of antiplatelet therapy they may be on, and then the action to initiate if they need oral anticoagulation, or if they are found to be on both. It's really important that in that small group of patients that may need both an oral anticoagulant and an antiplatelet, that you always use a proton pump inhibitor to reduce the risk of gastric bleeding. So for those patients that fall into priority group 3, these are your patients that are in AF but are treated with warfarin, which is an effective medication for the prevention of stroke. But it's important to remember that it's effective when it's in the right therapeutic range. So you need to check the range using therapeutic range calculators on EMIS or System 1. If a patient is found to have a therapeutic range outside of the recommended target range and has poor control, then you would need to try to modify risks that contribute to this poor control. So you'd need to make sure they had good adherence with their warfarin. You'd need to check for drugs that interact and have an influence on control, and perhaps look at diet and alcohol consumption. If after making some of these changes, you're still finding this particular patient is poorly controlled, then you would consider a switch to a DOAC. So this brings us on to switching from warfarin to a DOAC. And this slide is a step-by-step guide on how you would safely initiate that process. And on the right-hand side here, there's a useful paper recently published that takes you through that process and is available to download and print off. So finally, we have developed some useful digital resources, and this first slide shows you digital resources that are suitable for patients to use when self-managing their atrial fibrillation. This ranges from a number of different products, including useful websites, as well as videos, support for smoking, and all of those links will take you to the relevant resource. On the next slide, there are a number of different resources that are aimed really at the professional to support their management of patients with AF.